Welcome. I'm Leanne Meier, and this is Once a Nurse, the original. I have been doing podcasts since 2017, and so I've kind of show up on lots of different areas of podcast platforms. So definitely do look for us on Apple, Spotify, Google Play, Buzzsprout, and YouTube, among others, I'm sure. So to look for this particular show, you'll want to look at Once a Nurse with Leanne Meier, and that'll be how you'll find us. So today I am really excited to have Rosa Hart is with me today, and she is a stroke nurse navigator, and she has her own podcast called Stronger After Stroke, which is produced by Norton Neuroscience Institute, or NNI. She started out with a bachelor's in music, and then from there went to a bachelor's degree in nursing at Indiana University Southeast. She's worked in neuro ICU since 2013, and she's done everything from nurse's aide to bedside nurse. In the course of doing that, she was actually nominated for Nurse of the Year, which I think is such an incredible thing. With over 10 years at Norton Healthcare in Louisville, Kentucky, she is now the stroke nurse navigator, as I said. She follows stroke patients after they're discharged home and leads stroke survivor support groups. Welcome, Rosa. Thank you so much for being here.
Thank you for having me today, Leanne.
Oh, I've been looking forward to this for a while. You are a new friend to me on LinkedIn. I think that's where we found each other.
Yeah.
And I'm always just so amazed at all of the things that nurses do. And this is one that I know nothing about. I've done a hell of a lot of things in nursing, but stroke is not one of them. So I'm going to be really excited to learn about the things you can share. And I'm sure there are people out there that don't know a lot about stroke, or maybe haven't had patients that are stroke, or it may even be family members that are watching this. So we're going to just kind of make this accessible to everybody. What I like to do, Rosa, is initially I like to have each of my guests tell me what brought you to nursing and what keeps you in nursing.
Well, that's a good question. What brought me to nursing? So I actually grew up in a family that tried to avoid going to the doctor if they could. They wanted to pray about it and hope that things got better. And I wanted to know more about how the body works. And I thought, well, if I'm a nurse, at least I can help my family if they're not going to the doctor.
Mm-hmm.
So I would love for that to be the case, and that has been the case in a couple of instances. But for the most part, if you don't want to go to the doctor, you don't want to listen to a nurse either. So that maybe didn't pan out the way I planned.
You know what? Even if you do have a family that goes to the doctor, when you're the nurse in the family, they don't want to listen to you.
Well, I don't know about that. So yeah, but as far as staying in nursing, I have found it really rewarding to. I have seen some miraculous transformations in stroke care, and I just feel like I'm able to make a tangible difference. You know, a lot of people like to check boxes off their to-do list, and you feel accomplished. And when I see the difference that I've been able to participate in making in somebody's life, then, that makes me feel like I've spent my time well. So,
yeah. What I used to hear a lot with my guests would be they went into nursing and found that they liked nursing, but they weren't quite sure of the actual place they wanted to be. And so it's really nice when you can find that place that just feels like, yes, this is home to me. This is where I can grow and develop and feel like I can really make a difference in patients' lives. So I'm really glad that you found this, and I love it that you're doing this podcast. So tell me a little bit about, in fact, if there's something else that I didn't mention in the bio, feel free to fill us in on anything.
No, I think you summarized it well. And so in that whole time that I was in the ICU, it was all neuro ICU. So I like to say I didn't know I was supposed to be scared of neuro because I would float to other units and they'd be like,
Uh-huh.
"Oh, no, I don't do neuro." And I'm like, "Why not?" But, if you do an EKG, then you have your answer about what's electrically
Mhm.
going on in somebody's heart, for example. And there's a lot about the neuro assessment that's more intuitive. Since that's where I started, I was able to pick up on that as I was helping the neuro nurses give baths and do their assessments. I was helping with the tasks, but also learning the nuances. So I think when I got out of nursing school, it was already kind of built in that experience. So
you had clinical experience in neuro while you were in school.
right,
Oh,
exactly.
that's really good.
Mm-hmm.
So, when you started to get more, get your feet really wet and felt like you were more confident, what was it? Was there something that happened that made you say, "Okay, I got this. I can do this"? I don't know if an experience happened for you or something that just really made it final.
Yeah, I had some very encouraging people that I worked with. So I started off on night shift and a more general neuro ICU, and then I transferred to day shift in a very specific stroke ICU at a comprehensive stroke center where they
Uh-huh.
get patients in from all over the country, or not the country, all over the region. I'm sorry.
Okay.
I I get excited about
The
the
countryside, maybe,
the
huh?
countryside, the Kentucky countryside. Yes, with the bluegrass.
Yeah,
And so yeah, they came from far and wide. And when they got there, we had all these experts, and the culture at the time was the neurosurgeons and the neurologists were like, the only dumb question is the question you don't ask because
that's good.
we want you to know the answer. So we're all on the same page. So that was such a great learning environment to grow, because if you feel like somebody's going to talk to you like you're stupid, then you're less likely to ask a question and then you just
Right.
perpetuate your ignorance.
And you're sure not going to call them in the middle of the night when you don't know something.
No kidding.
Yeah.
Yeah.
That's one of the things I've always been really frustrated with because, especially that whole thing with nurses, judging each other and kind of not just assisting because we all have been exposed to some things, but not other things. Every single nurse has things that maybe they never heard of before. They don't know what that is. And so I'm with you. I want to know I'm in an environment where I can say anything that I don't know and feel comfortable. I'm going to get an answer. My problem is when I've asked that question about 3 or 4 times and they start saying,
Oh,
when are you going to start remembering this?
yeah. That is
So,
a challenge.
so when you are like precepting the new stroke nurse, what is it that you want her to know?
Oh, there's so much. And honestly, like I've been away from the bedside for the last 3 years and a lot of things have changed. So, a really good neuro assessment, head to toe, every time. Start with alert and oriented times 4 and work your way down, check pupils, and literally just go all the way down to the toes and be thorough and be able to describe your neuro assessment. One thing that even nurses in other specialties may be familiar with is the NIH, because if someone has, for example, a carotid endarterectomy surgery, they may need to have that assessment done, and that gives you a number. But if you call a doctor with a number, they don't want to hear a number. They want to know specifically what
What are
neurological
you
symptoms you're
seeing?
seeing.
Right.
And
And I don't know what NIH is, so maybe other people don't either.
right, and I mean, we have the National Institute of Health,
Oh, that's
right?
what you
So
meant. Okay.
we abbreviate NIHSS. We call it the NIH, but it's the NIH stroke scale. So,
Okay. Okay. So that brings me up to scale, up to start. So with what you're doing as a nurse navigator, can you tell me a little bit more about what that's involved? Because one of the things I'm really trying to do is help nurses know that bedside is not the only
mm-hmm.
place that a nurse can be. And
Yeah.
many times these are the kinds of things that people, wouldn't know about unless somebody shares that with them.
Right. So the position of a nurse navigator in general has been growing across the country in different specialties and in primary care. And a navigator helps someone navigate a health system or a disease process. Like there might be a diabetes nurse navigator or a stroke nurse navigator, where in my case, I will call someone who's had a stroke after they get out of the hospital, talk to them about their medications so they know what they are, what they're for, what side effects to expect, talk them through like if they have difficulty paying for those, get them connected with social workers who can help them get that financially figured out, and then talk about the importance of primary care. And then we have primary care nurse navigators who help coordinate things through that office to keep people out of the hospital. And there has been evidence shared. I know at the American Stroke Association's last International Stroke Conference, they shared a study that proved that nurse navigators do prevent readmissions. So there is evidence.
And they speak with, not to or at the patient.
Yes.
And recognizing that this is a person who does not have all their faculties. They may be feeling still very out of sync. I just had a year and a half of having my thyroid off, and my mind was just a mess. So it gave me a little bit more of an idea of what it feels like to have some dementia, and or you can be speaking or seemingly acting okay, but you really aren't taking in what people are saying. So I know that when you say you're talking to patients after they go home, you're also talking to whoever is the caregiver or caregivers. So do you bring in the whole family to do like a family conference to hear this, or is there one person you're teaching?
If there's a family conference, that usually denotes a much more serious conversation. So I normally call to speak with either the patient or their primary caregiver. If they can both be on speakerphone, then that's wonderful. I don't try to talk to more than two people at once, because then there's too many cooks in the kitchen, right? But it's frequently when someone has a stroke and they're affected by aphasia, which is their ability to communicate. It could be a lack of understanding what's being said or not getting out the right words. Maybe they're saying lots of words that don't make any sense together. Or it could be like they might know what they want to say and be completely mute.
Right.
They just can't. So in those cases, I have to be talking to the primary caregiver. Otherwise, that's the only person I can talk to. Yeah.
One of the things I used to worry about would be locked in syndrome, where, whether that's from a stroke or some other kind of an accident that's happening neurologically in the brain, where you would be aware of what's going on around you, but not able to communicate anything to anybody else. I don't know if this is something that you have come across.
Yeah, I've encountered two of those, one when I was at bedside and one since I've been out. And, sometimes it really pays off when you don't give up on somebody.
Yes. Yes, I can imagine that.
Once you can define that they are locked in, then that means there might be some hope. So
if anybody wants to have some understanding of what it's like as a patient like that, I had read a book called The Butterfly and the Diving Bell. It's a very thin book, but it was written by the editor of a very famous magazine in France. And now I'm not going to remember which one it was. But I believe he had a car accident as a very young man. And he was, in this elevated position. And he could not move. The only thing he could do is move his eyes. And so he ended up, eventually over time getting somebody to work with him, go through the alphabet, and he would blink which letter he wanted. So you're spelling out words. He wrote this book by spelling out words by blinking his eyes.
One letter at a time?
One letter at a time. And I'm sure that the person who was working with him started to get, an idea of where he was going with things and probably sped things up. But he died shortly after the book was published. So it was like that was really what he wanted to do, was to get this out. and then he left.
Wow.
So, can you tell me? Well, let's start with. I know there's probably a mnemonic of some sort to help us remember what, like, are the signs of stroke, and most of us. I usually remember the mnemonic, but not what it means. So,
Okay.
yeah. So, why don't you share with us what that would be?
Yeah. So we use be fast. So B is for balance. So a sudden change in balance can indicate a stroke. Some people are already wobbly, so this would be a change from what is normal for you. And then
Yeah.
E is for eyes, a sudden change in vision. It could be double vision, it could be blurred vision, it could be a loss of peripheral vision. And then F is for face. I think a lot of people would recognize that a facial droop indicates a stroke. A is for arms, and oftentimes we have someone hold out both arms to see if one is weaker than the other, and that applies to legs too. So if you have sudden onset of one-sided weakness, that's a pretty clear sign of a big stroke.
Mm-hmm.
Then S is for speech, and like we said, it could be those difficulty with words and expressions. It could also be a slurred speech. Some people may sound drunk. So a lot of people have had missed strokes because someone assumed that they were drunk and shrugged it off. And then T is for time, where time saved is brain saved. And it can also be for terrible headache. With some kinds of hemorrhagic strokes, you might have a thunderclap headache, and then it's a sudden onset of the worst headache of your life. So even if you're a chronic migraine sufferer, this would be different. It would be
So, by
sudden.
thunderclap, do you mean there's a sound? There's a
A
loud
lot of
sound.
people describe hearing what sounded like a thunderclap inside their head, followed by the worst pain in their life.
Wow. Yeah. So, what are some things that cause stroke? So, I know stroke
Yeah.
is pretty broad. So, what
Yeah,
are
it's
some
like the
things that
leading
cause
cause of
it?
disability in the United States.
Wow.
And so it's very important that we know, well, what can we do to keep this from happening? And there are some genetic factors. Unfortunately, we cannot change our genes. So when I call someone after they've had a stroke, we try to focus on what are known as the modifiable risk factors, the things that are within our control that we can focus on adjusting. And that can include blood pressure. We want to get our blood pressure to less than 130/80 on a daily basis. And then cholesterol. We usually aim to get cholesterol to the LDL to be less than 70 and the HDL, which is the good cholesterol, to be greater than 50, because the good cholesterol carries the bad cholesterol out of your body.
Right.
And the only way you can raise your good cholesterol is through exercise. There's
Okay.
nothing you can really eat to make that better.
Beat me across the head here.
Well, it applies to all of us.
Mm-hmm.
And so let's see, diabetes actually doubles your risk for stroke.
Wow.
Whatever your other risk factors are, diabetes doubles your risk for stroke. That having high blood sugar is hard on your entire body,
Right.
and causes organ damage of all kinds. So
One of the things that I remember back in years ago, I was working with diabetics for a while. And at that time, they were looking at when people came into the emergency room, that being one of the number one first things they ask people, because it impacts so many other things. If they have diabetes, there's going to be a whole bunch of things they're going to need to look for. I
and
think,
one other thing with I'm sorry.
Go ahead.
One other thing with diabetes is a sudden shift in blood sugar can mimic stroke symptoms, especially like balance and things like that, and vision changes and change in level of consciousness. So when someone presents with stroke symptoms, the very first thing that EMS or the ER is going to do is going to take their blood sugar to eliminate that as the culprit. Because if so, it's a really easy fix.
Yeah.
Give them some sugar.
Yeah. I can imagine, if they were coming in and they're not conscious, running in your brain through, okay, how many different things could this be? But you're right. If
Mhm.
you can give them sugar and they come out of it,
Mhm.
that solves that problem really quick.
Yeah.
I know I have a brother that has obstructive sleep apnea,
Mhm.
and he cannot even fall asleep for a nap without having a CPAP
Good.
on. And so I know that's one of them. And I'm guessing that smoking and some other things like that is probably maybe alcohol, and some of those things are probably issues.
Yeah, so let's clarify that because you're right, but we can't just like blanket statement, especially with alcohol, because
Right.
they say one glass of wine will decrease your risk of an ischemic stroke, which is caused by a clot,
Right.
but having an excessive alcohol makes you more likely to have a bleeding stroke, which is a
Yeah.
hemorrhagic stroke.
Yeah.
So there's a balance
The other
there.
thing that comes into that is my opinion of what's excessive and your opinion of what's excessive.
Mhm.
And so I found that when I'm working with people that do drink and are having symptoms in their body because of that, you have to be really specific with them about what we consider excessive and that can cause negative changes in their body.
Mhm.
I had one guy that was saying, "Oh, I just, I drink the same amount of beer that everybody else does." And I, when I finally got clear from him, it was about a case of beer in 2 days. So over 2 days, he was going through a minimum of a case of beer, and probably more than that. That was what he was willing to tell me about.
Right, exactly. Don't they say
Yeah.
multiply by 4?
Exactly. So, what are some of the things when you're dealing with somebody that is having a stroke? They don't know what's going on to them, that people are talking to them, maybe telling them, maybe they can't either hear them or understand the words that are being said. How do you help calm them down or calm yourself down, whoever it is that's trying to talk with them? And then tell me about going to the emergency room. Why is that important? And
Mhm.
how do you get that to happen? And is there a time period? You mentioned time before. So is
Yes,
there a time period in which you want to get them to the hospital?
definitely. So, first question was about how do you comfort someone who is experiencing a stroke? I definitely don't want to promise them any good results. Don't want to make any false hope type promises and then have somebody say, "You promised you would save my dad," and then you don't. Don't want to set yourself up
Mhm.
for that. So, what I would always do is let them know you are not alone. You are surrounded by people who do this every day, and we are going to do our best and take care of you, and we're going to be with you the whole time. So, things
What
like that
what
that
I
are
remember,
grounded in the
we
moment.
were we were always told to give them an aspirin, even if they weren't conscious, to put it under their tongue or something like that. And I think that's changed, but tell me about that.
That I feel like that's still recommended for heart attacks,
Okay.
but for stroke, if you're having a stroke, you may already be on a blood thinner like Eliquis or warfarin, and you don't want to give anything until you know what they're already on, and because we don't know if it's an ischemic stroke or a hemorrhagic stroke. You don't want to make them bleed more. So um, we get them in the ER as quickly as possible. So we do activate EMS by calling 911. We don't drive to the nearest emergency room. They're not all created equal, and that's not a diss against anybody. But when
Mhm.
you call 911, those uh, EMT and paramedics are trained to recognize what's known as a large vessel occlusion, which is a large artery. And when that is occluded, they may be eligible for what's known as an endovascular mechanical thrombectomy. And that's when a neurosurgeon can go in their artery and pull the clot out of their brain. And there are only comprehensive stroke centers that can do that. You may be eligible if you have a last known well where you were awake and normal and someone saw you, or you can report that you are normal within the last couple of hours, then you may be eligible for alteplase or now tenecteplase. Those are also known as TPA and TNK. Those are clot-busting antithrombotics that can be given IV, but only within the first 4 hours of the onset of symptoms. So after that, there's just too much risk of bleeding, so they're contraindicated. But if you...
Can those be given in the ambulance or by an EMT?
No.
That's
so
what I thought.
The EMS has to take you to the ER to have a CT. The CT has to, of the brain, has to show that there's not already a brain bleed happening, because you don't want to throw a clot buster on top of something that's already bleeding.
Already bleeding, right. Mm-hmm. Even if it's bleeding just minimally.
Yeah, no.
I do know Kentucky. I used to visit there, not a lot, but enough to know that it's very hilly and mountainous, and that there's many times long distances between maybe large hospitals, like, obviously Louisville has, and some of the other major cities. But what about somebody who's having a stroke out in their field? I mean, what can be done to help get them to, emergency help and get to a hospital as soon as possible?
Well, if it's a 911 call, and they can describe the symptoms, then the 911 operator should hopefully be able to identify if it would be appropriate to send out EMS or an air ambulance, and then lifelike them to the nearest hospital.
So they could actually go to the farmer's field and pick him up in the field and take him back?
I mean, I don't know the parameters, but they can definitely go a lot further, a lot faster. So
that's for sure, and go right over the top of everything.
Yeah, so I'd always start by calling 911.
Yeah. So once, if I was admitted to the emergency room, what might I be able to expect would happen to me? I mean, you mentioned that
they better take your blood sugar.
Fast.
They better take your blood sugar first thing. And then a CAT scan, yes. A CT to look at the brain to see if there is any sign of bleeding. If there's not a sign of bleeding, they're going to also continually be assessing you, like pretty much nonstop, because as soon as they finish a neuro assessment, they're going to start over again and see if there's any active changes happening, if the symptoms are going away, if they're getting worse, because that will affect whether or not they decide that you're a candidate for alteplase, TNK, the drugs, or if you're going to need to be transferred to a comprehensive stroke center that can do the neurosurgery required. So it's a constantly evolving process that has to move really quickly. So time is of the essence. And so I will really believe that all nurses need to understand the time-sensitive nature of this. And if you are working in a place that is not stroke certified or stroke prepared for those things, then the priority needs to be getting them to the level of care that they need. And there's a map for that.
And I know that, you feel pretty much comfortable once you get to the facility. But since COVID has come, we are having situations where hospitals are very, very full all the time, whether there's, some kind of a major illness going around like we had with COVID, or it could be just on a specific day where there's accidents or there's, a number of different things going on, and you come into the ER, because what you described sounds to me like somebody needs to be almost one-on-one with that person. So
100%, yes.
Yeah. And so I guess I'm wondering, as
it's not just one-on-one, there's like 10 people.
Okay.
You're going to be surrounded. You're going to be surrounded. You better be surrounded.
Yeah. So I know as hospitals are closing in, some of the rural areas and the lower underserved urban areas, how are they looking at how we're going to handle some of these situations?
We want to transfer to the highest level of stroke care possible.
Okay. I'm hoping they're thinking of, okay, we better be replacing some of these places that have been lost, at least on an EMT level, so that there are more, spots around the state that can help.
If they want to do a mobile stroke unit and have a brain scanner in the stroke unit bus. I know that I think they tried that at some of the like experimental facilities. So
Okay.
that would be the dream to
Okay.
just take everything there and they can give TPA on the spot. But
Well, maybe we can end here and with our dream. And is there anything else that we haven't talked about that you really want to make sure you get across?
definitely. Once someone has a stroke, whether or not they had that intervention, I really want everyone to know that neuroplasticity, it has revolutionized stroke care. So, 20 years ago, somebody had a stroke and you just assume that's how they're going to be stuck for the rest of their life. But that's no longer the case, because we realize that even though brain cells die and you don't grow new ones, the ones that remain will stretch and look for each other if you direct them in the right direction. And you can regain that function, and those nerves can learn to do new things and different parts of the
Good news.
Yes, it is. So my podcast Stronger After Stroke um, shares so much about how that works. We've got some stroke survivor stories teaching about their experiences with aphasia, having young strokes that left them with symptoms that are invisible, but and they may not feel good about talking about it usually. So talking through like the emotional coping of life after stroke, which is something that there's a big need for. I also got to interview our headache specialist on migraine and stroke, and some therapists talking about anxiety and depression after stroke and how to cope with that. We even have 2 episodes on sex after stroke with a certified sex therapist and pelvic floor therapist. So it's an arsenal of experts. And my goal is to get it out to everyone who needs it anywhere in the world, wherever there is the internet. And they don't have to come here to get it. They can have it in their home.
Rosa, if people hear this and they have questions for you, how can they get a hold of you?
So if you go to nortonhealthcare.com/stronger-after-stroke, you can always contact me that way through commenting on the podcast on YouTube. You can also find me at rosa.hart@nortonhealthcare.org, and that's my email. So I'd be happy to hear from you.
Well, I'm very happy to have heard from you today. So thank you so much for joining me today and for sharing all that you have. I'm sure that what you're saying may be enlightening to some people and give them hope if they're in that situation where they've been diagnosed with a stroke and they're thinking of all those past myths. Well, they were probably true at the time because that's what we knew.
Yeah.
But now more of it's moved on from there.
There's hope.
Yes, there is hope. I like to end on that. Thank you so much again.
Thank you for having me, Leanne. This was a pleasure.
You're welcome.